This is a young lady who had a previous scoliosis correction. She had an anterior procedure done. She did very well for about 3 years, then started to develop some back pain. And if I zoom into this, you can see here her rod, and you can see how the rod is broken right at that spot there, which is consistent here and probably meaning she's got a pseudarthrosis right through that level, so the bones haven't healed. This is kind of a unique case. There are many ways to try to address the pseudarthrosis and the pain. The other issue that she has is that she's pitching into kyphosis above her fusion. You can see how she's collapsing down here. So my goal for today is, one, get her back into a more normal thoracolumbar sagittal alignment, and we're going to do that by creating little osteotomies here to essentially do a Smith-Peet type or Ponti type osteotomy to shorten her back here and realign this segment. And then the second part is going to be to bridge this pseudarthrosis and compress down from behind on this graft. Now, one of the unique things, and this is where I believe the robotic system here is going to help us in the preoperative planning, because we've got these anterior screws in place. I want to make sure that my pedicle screws aren't hitting up against these screws here. So if we go to our planning, you can see how I've been able to place the screws, and I know the length. Here we can place a shorter screw on the left-hand side, a little longer screw on the right-hand side at L3. At L2, again, we've got 2 screws so that I'm missing the screws that are in there. But at L1, where I really need good purchase, you can see on the lateral that I've been able to aim the screws above the previous screw that's in place. So I know that they're not going to butt on each other. And if we go through the planning, you can see right here on the coronal shots, as I go image by image, we've been able to position the screws away from the others. The other thing that she has is this little staple here as part of the anterior instrumentation. So you can see, doing this freehand, I may run into this. By using the robotic preoperative planning, I'm able to place those screws exactly where we want, and I know I'm not going to run into the already existing screws in her spine. Likewise at T12, I'm able to position the screws well away from the screw that's going across her vertebral body. So again, if you look at the preoperative planning, you can see this screw's already gone. These are coming into view now, and I've got this well away from any of the other metal that may deflect or bounce off those screws. And then the rest of the vertebral bodies, T11, 10, 9, 8, they're all pretty straightforward. One of the things that I really have learned to appreciate with the preoperative planning is the trajectory of the screws so that we can line up our implants. I like to use fixed head screws as opposed to the polyaxial screws, particularly for the corrections. I believe you get a better correction with a fixed head screw. So as I go level by level, I can keep the trajectory and the angle of the screws symmetrical. So they're all pretty close to a 10-degree trajectory as I'm going through this, yet still keeping the screw well within the vertebral body and well within the pedicle. Another issue is anatomy that you may not otherwise appreciate. So here you can see I've got a very thin pedicle here. I want to try to keep a 5mm screw, and I don't mind if we have a little bit of a lateral breach. Clearly we do not want any medial breaches. So this is essentially going to be an in-out, in-placed screw with a little bit of it here. I could drop it down to a 4.5mm screw, but I'd still rather keep the 5mm screw. And then we can just go all the way up and down, making sure that each level is planned out and we've missed all the other screws. Good.
Okay. Yeah.